The subject today is where next for digital health. We've got a fabulous group of panelists that bring with them a vast amount of experience. So I'd like to introduce the rest of the panelists, or ask them to introduce themselves.
Hi, I'm Martin. Good morning. Now it's 11 o'clock in Sweden. I'm from Sweden, but I guess it's almost morning in Britain. I'm the Chief Medical Officer and co-founder of Yazen Health. It's a digital health care provider for medical weight loss, obesity. Thank you for having me here with you today. My educational background includes medical studies at the Karolinska Institute in Stockholm, as well as doctoral research on type 2 diabetes and obesity genetics at Lund University in southern Sweden. I'm currently also an associate professor at Linnaeus in Sweden, where I specialized in endocrinology and big data. Excuse me. I have dedicated my career to understanding and treating chronic conditions like hypertension, high blood pressure, type 2 diabetes, obesity, and other metabolic disorders. My passion for improving healthcare led me to found Akumbu. It's now called Blood Pressure Doctor. It's an e-health company aimed at providing more accessible blood pressure care. And most recently, I co-founded the digital healthcare provider Yazen Health, which focuses specifically on obesity treatment that lasts. We integrate the proven medical weight loss medications with expert lifestyle guidance from our team of doctors, dietitians, psychologists, and personal trainers. This approach with a team is proven to be effective for achieving long-term and sustainable weight loss. We have now thousands of active users, that is patients with obesity, and are now expanding the service to treat those with obesity across Europe. So effective treatment of obesity typically is multidisciplinary. So Yazen patients, they have access to our specialist team with our app and our digital platform with our electronic health record system, the journal system, providing the tools for treatment. We are now also using these new revolutionary obesity medications that you probably have heard from, that are now available to help our patients to reach and keep a healthy weight. But effective medication is not all that is needed for effective treatment. In my research and clinical work, I'm particularly also interested in leveraging technology to make quality healthcare more convenient and personalized, patient-focused care. So I believe digital solutions like Yazen Health can empower patients while also enhancing physicians' ability to manage chronic diseases such as obesity. This is the vision that drives my work as a clinician and entrepreneur, to use science together with modern technology to create meaningful change in how we monitor, maintain, and improve health, especially chronic diseases such as obesity. Thank you.
Next up, Marcus from Osbourne, Clarke.
Thank you, Alistair, and thank you, Martin, for that introduction. I'm on the other side of the fence in that I'm a legal advisor. I'm head of digital health at a law firm in the UK called Osbourne Clarke. We're one of the market leaders in advising on digital health issues in Europe. We've been advising three groups of companies, or three different types of companies, for the last 8 years with a distinct digital health flavor. One is technology companies moving into digital health. Secondly is life sciences and healthcare companies who are becoming more digital and adopting new technologies. And the third is disruptors, so standalone digital health companies. And we've been lucky enough to act for some of the market leaders and unicorns and some of the startups as well in the digital health sphere. I'm really interested to hear what the esteemed panelists today are seeing coming down the track in 2024 for many of us. I think 2023 was a bumpy year. I'm therefore interested to hear what the panelists think is coming up in 2024.
Great, thanks very much, Marcus. Mark, can I ask you to introduce yourself, please?
Thank you, Alistair, and thanks for being included on the panel. My name is Mark Ratnarajah. I'm a paediatrician working in the NHS. I'm also a managing director at a company called C2-Ai. We probably best describe ourselves as a precision analytics company that is AI enabled. We work primarily in the UK with the NHS, and we support a range of analytical capabilities that really try to democratize information and sort of empower clinicians and operational teams the best use of the data that they have. So that ranges from looking at risk-adjusted outcomes to better understand variance to practice and opportunities for quality improvement. And more recently, that's also had a bearing on inequity and ensuring and remediating that vulnerable groups, particularly those affected by social determinants of health, aren't losing out in terms of the quality of healthcare they're receiving, and trying to understand what are the underlying reasons for that and trying to do something about it. And then at the other end, which has really been sort of post-pandemic, we've been supporting risk prediction, primarily for elective recovery. So identifying the risks of patients whilst waiting on the waiting list. And as we all know, the waiting list is going up. Patients are waiting for longer, and that's presenting a unique set of challenges for clinical and operational teams in terms of the impact of both the underlying condition of patients as well as the impact of their comorbidities, resulting in potentially poorer outcomes because they're having to wait for their surgeries. And so we look at understanding that dynamic risk as well as predicting those patients who may well deteriorate and actually trying to quantify what that level of deterioration might be. That in turn helps support better understanding of which patients potentially need to be expedited and what level of support can be used, particularly in the form of anticipatory care pathways. So we're kind of using insight to drive action, particularly in terms of proactive management, resilience of patients, and moving forward biopsychosocial models and patient agency to help drive some of those health improvements ahead of surgery. The net impact of that is really around how can we best use the scarce healthcare pound or dollar, depending on where you're operating from, so that we can help use innovation to drive some of those decision making in order to have sort of better efficiency in the scarce resources that we have. But very nice to meet you all. I'm very much looking forward to the conversation today.
Thanks, Mark. And I'm sure we'll return to some of those points around efficiency and best use of resources. Neil, can I ask you to introduce yourself, please?
Yeah, thank you, Alistair. And nice to meet everyone as well. So I'm Neil Perry. I'm the Practice Director for Innovation and Data Science for SmartCo Consulting. As the name, we're a consultancy firm working in digital health and also on the private sector, but on the digital health side, we help NHS Trust with their digital strategies, their business cases, and their implementation of digital health solutions. We also help suppliers position their solution into the market and understand the NHS as well. So everyone at SmartCo has got a deep NHS background. I myself have got 25 years prior to jumping into consulting, 25 years in the NHS. I was the CIO for an NHS trust down in the south of England for worked there for 16 years and other places as well before that. I got myself known as being one of the most innovative CIOs in the UK through the CIO 100 and things on their ranking system. And that was from bringing into the NHS real world use of innovative technology. So I was the first to bring in wearables back in 2017 and worked with the company to design and build that and pivot their solution to make it fit for the NHS and really solve a gap in remote care, what's now known as virtual wards and things, that kind of technology. Artificial intelligence as well, so bringing chest x-rays, AI into diagnosing cancers and reducing the length of time to understand if a patient's got cancer or not, to get them into their MDTs from 6 weeks down to next day, which is quite nice to do and quite an important thing. Also worked on stroke models and stroke prediction and prevention as well. So lots of different bits, pieces, and lots of data science use of data to create medical calculators to help prediction. So yeah, that's me and SmartCo. Thank you.
Great, thank you, Neil. And last but not least, Paul, if you could introduce yourself, please.
Yeah, thank you, Alistair, and great to meet everyone today. So I'm Paul Landau. I'm the founder and chief executive of a company called Careology. We operate in what we call the digital cancer care space. My background has been in health tech for about 20 years. Prior to starting Careology, I was the founder of a company called Fitbug that way back in 2005 was probably one of the first players into what's now known as the wearables category, which Neil, you just kind of mentioned in your introduction. And interestingly, I actually never saw Fitbug as a wearables business. For me, it was actually all about how you use the data that can come off a device and put that data to work to actually help somebody then achieve a health outcome that was important to them. So it was never about the shiny little gadget that you could carry around in your pocket. It was about how do you take data and insight and use that to help somebody achieve a health goal. And just kind of picking up on a couple of other themes throughout other people's introductions, we ran things like weight management programs using devices and data to help nudge and motivate people to keep more active and improve their diet. So very much looking at things like energy balance. But long story short, I ran that business for 10 years. And then actually in 2015, initially, my wife was diagnosed with Hodgkin's lymphoma, so a blood cancer. And it was kind of my experience of supporting her through such a daunting cancer pathway, as obviously any cancer diagnosis is daunting, blended with kind of my background in the health tech space, where I really just saw so many opportunities for how digital should be better employed to support people going through a cancer pathway. And I was actually quite surprised when my wife was first diagnosed, really at how little there was available digitally to support people going through such a long and complex pathway. So really, once she was in remission, I had an itch that I had to scratch, and lots of ideas around how we could use, again, data and devices and great user experience built around powerful software that could better support both the patient going through a cancer diagnosis, whilst connecting that person to friends and family, acting as caregivers so they can perform that role more effectively, but critically to then provide information back to clinical teams so clinicians and the whole clinical team can start to understand how their patients are beyond the four walls of the hospital, unlocking a broad range of different benefits. And no doubt we can talk about some of those throughout the webinar. So lovely to meet you all, and thanks for inviting me along today.
Great. Yeah, thanks, Paul. And we'll definitely come back to talk about patient engagement and the role of digital in that. The subject today, of course, was where next for digital health. So it'd be really interesting to just go around our panelists again and hear your sort of predictions and thoughts with reference to what is coming down the line, the big breakthroughs and the big developments that we think we'll see, we hope we'll see over the course of the next year or two. We'll do that in order again, Martin, and if I could ask you to start, please.
Yes. Interesting thoughts you have. And I think that one breakthrough with digital care is that, the healthcare is traditionally, it's built 100, 200 years ago. It's reactive. It's built for acute illnesses, and you go to the hospital, you have a visit, and they treat you with something, antibiotics or your broken leg, and then you go back. But nowadays, people, they have not so many acute illnesses, they have chronic illnesses. We can often not, they need treatment every day, and they need monitoring, like with the devices that you talked to, Paul, and I think it was Marcus. For example, scales and blood pressure, and how active you are in living. And what you want with these chronic patients is that you want to, you don't want them to have acute illness from their chronic disease, like, for example, hypertension or obesity. It can lead to type 2 diabetes and stroke and heart diseases and other illnesses. And you need to empower patients to make them possible to prevent the disease and to monitor them in their home and give them accessible care, so they can reach the doctor or the healthcare provider easily. So and I think that is, I mean, the big breakthrough with digital health, that it's accessible and that you can monitor people in their homes. Yes, the one of the things that I was thinking about is that, and I think it will be more and more, and you should use physical examinations only when it's necessary, because you don't want to I mean, it's unnecessary to have a hospital and do a lot of examinations when you don't need it. It's better to have those kind of examinations for those who are really in need of it. So that is my opinion. So I think it's a good future for healthcare. It will lead to a lot of beneficial things, and also now we have AI. I guess you will talk about that maybe also, because then you can have better clinical decision support systems for doctors and also for patients, empower patients in their homes. That is my meaning. Thank you.
Great, thanks, Martin. It would be interesting as the discussion goes on to think about how long that kind of fundamental shift will take, or whether or not it's already well underway. I guess it may well be. Marcus, could I ask you next for your thoughts?
Thank you, Alison. Thank you, Martin. If I could just pick up where Martin left off, I think that this year is going to be a year in which we'll see three things happening. The first is machine learning about everything. The second is related to money and funding. And the third is in relation to problem. So we'll deal with them in that order. The first is the machine learning. All of our clients in the digital health space are looking at how they can best employ the capabilities and the functionalities of the new machine learning applications that they have either developed themselves or that are now available in the market, whether that's from B2C patient care, or it's at the other extreme, drug discovery. I'm not aware of any of our clients who are not talking about machine learning in some capacity. It will be interesting to see who will be the winners and losers that fall out at the end of 2024, because as sure as eggs are eggs, the winners will be those who have most effectively employed machine learning to speed up whatever they're doing, to make more relevant whatever they're doing, to cut waste out of whatever they're doing, and to drive efficiencies. Those who will fall behind will those who are not at the leading edge of that curve. The good thing for digital health compared to many other sectors in the wider economy is, I think, right at the core of digital health from the get-go has been machine learning. And I think that digital health is well placed, therefore, to be on the bleeding edge of machine learning as we go into 2024. But there will be losers that come out of it, and there'll be those who do not have a digital health strategy with machine learning at its very core. The second is money. 2023 was a bloody year for many digital health disruptors, in that whereas coming out of COVID, there was a lot of cash floating around in the market being attracted to digital health businesses. 2023, that dried up, especially in the latter part of the year. That means going into 2024, we're going to see, I suspect, a wave of consolidation. Maybe some companies that run out of money and fail, freeing up technologies to move and be bought on the cheap, freeing up people to move to those companies which still have money. and I can see 2024 being a year of great realignment. The winners inevitably will be those with either the most revenue or the deepest existing pockets, and there are players in the market who have got a lot of money coming out of COVID years. There are others who are anticipating raising new Series A or Series B or Series C at the beginning of 2024, and that money just isn't there in the way that it was a couple of years ago. I can see the big technology players being winners. I can see the big pharmaceutical companies being winners because they have resources with which to snap up companies which were formerly standalone, and they're both big businesses or types of businesses who have a hunger for digital health divisions within their offerings. So what we're seeing is a lot of positioning ahead of that consolidation wave in 2024. And the third is a scandal. I shouldn't really end on a negative. It's still surprises me how little attention is given to some of the companies in the industry as to the importance of data protection and the effect that a data protection breach is going to have on a business is going to become apparent this year. Where that's going to come from, God only knows, but the scandal that will impact digital health, I suspect, in 2024 will be led by a data breach of some description, which will drive to the core of a business's ability to be trusted by business partners and its customers. And we can only hope that that doesn't happen to anybody that we're involved in, but it's about time something like that happens, sadly. So they're my three things: machine learning, money, and consolidation this year, I suspect, and there will be a major data breach, a newsworthy data breach.
Thanks for that, Marcus. And it is an interesting point when so much depends on data and its integrity and the way it's used, that there is trust at all levels, particularly amongst patients, for the way that data is being used. Mark, can I ask you for your thoughts on what's coming down the line?
Thank you, Alistair. Marcus and Martin raised some really interesting points and certainly resonate with some of our observations. I'd probably go on to sort of say that I think in the next sort of couple of years, we're probably going to see the impacts of things like the federated data platform and sort of interoperability of data becoming much more at the fore. There is no end of data within healthcare. I think it's probably one of the second highest generators of data by industry. But the problem is it's all siloed. It's not very easily accessible. And actually, part of the fundamental problem within healthcare is a lack of communication between organizations, and actually being able to connect the dots is in and of itself going to fundamentally shift how healthcare is delivered and lead to the opportunity for more creative ways of dealing with healthcare, both in terms of using lead indicators rather than lag indicators, being able to shift, as Martin said, more healthcare back into the community and start to think about anticipatory care pathways, patient resilience, being able to provide patient agency and autonomy through data and enablement of data. And also being able to use insights to drive some of those pathways of care. So rather than being wedded to bricks and mortar, I think there's going to be much more of a drive around demand management and demand prevention. But that only comes from being able to access credible data in near real time that's meaningful, that can be shared between the relevant agencies. Marcus raises a really interesting point about how you manage information governance, and clearly information security needs to be paramount. But the flip side to that is actually there are quite a few patients who want their data to be shared, particularly those living with chronic disease. Their biggest bugbear is that actually information is ineffectively shared between the agencies that need to manage their healthcare, and they're constantly having to repeat themselves. They're constantly having to, almost provide their own portfolio information. Being able to share that more effectively and use that to enable their care, I think is going to be more important. I certainly think that sort of post-pandemic, the acceptance of digital technologies is far more far more relevant in terms of delivery of care. And I think also, to Marcus's point, there needs to be much more focus on value-based procurement in the medium and long term, rather than it being very staccato and very sort of short-term funded base. Because actually, in order to shift those changes, one needs to be able to have a sustainable revenue model in order to be able to innovate and do those sorts of things in a sustainable way and do it effectively. So, I think things like the federated data platform may well have quite a sort of turnkey solution to some of these things. And I think the work that, some of the participants on this call are doing, particularly in community-based healthcare, as well as some of the work that we're doing around insights, are going to drive some of those new innovations, particularly around pathways of care and putting the patient right at the very front of that decision-making process.
Thanks for that, Mark. Neil, your predictions.
Yeah, thanks. I think along with predictions, understanding where we are at the moment is really important for that. And if I concentrate on the NHS side of things, UK NHS being the biggest healthcare provider that we've got, we do have private and it's obviously segmented into lots of different areas. But we're in the foothills at the moment, I would say, of digital health, where the NHS is behind other countries. Got Europe further ahead than us, Australia, America, they're all further ahead in their digitalisation. And therefore, we know there's £2 billion being invested into frontline digitisation in the UK over the next couple of years. And that started year before last. There's a 3 to 4 year, I think it ends now in 2026. That won't be the end. We'll only see a number of NHS trusts reach a HIMSS level 5 over the next year or two, and there'll be, in the next government review of funding, more money will have to be put into achieving more. And that's on a HIMSS level 5. We can go to 7, and 7 is really only just the start of when we start talking about all the really nice innovative technologies. But in terms of prediction, Marcus, I think your point around consolidation is absolutely key. I think we've already started to see that, certainly in the medical device industry. We've seen large medical device suppliers in America being bought up by even larger pharmaceuticals companies, and them consolidating both pharma, biomed, and then medtech as well, which is absolutely where I think we need to be going, bring those data insights together and put in there. But they won't achieve much without the healthcare providers being ready to utilize the data, and that's where the basics of frontline digitization is going to help. If we look at things that have been shared already, so the Global Health Observatory and papers by Deloitte and things like that, it predicts that digital health will be 26% of GDP by 2027. And that's 40 trillion globally. So that's a huge pot of money, a quarter of entire GDP. And I think that will be spent more on, once we get the basics in place, the shift then becomes to actually some of the stuff that everyone here is talking about, health condition specific developments. We get back to innovators rather than big global health solutions that will get consolidated and brought up and put into big portfolios. But it will be around patient conditions, more virtual care. Artificial intelligence is obviously going to play a massive piece of that. We talk around generative AI because that's what ChatGPT has been doing in healthcare initially, and certainly in 2024. I don't think we're going to see generative AI mainstream, definitely not. But actually, we probably will start to see parts of generative AI, things like large language models, start to get traction in healthcare, providing solutions to front-end clinicians or front-end providers, front care providers. Things like being able to provide a summary of the care. The patient's gone through their inpatient stay. A large language model could be trained to review what's gone on and provide the bones, a first draft of a discharge summary that takes junior doctors hours to complete. And that could be done in seconds and free up lots of clinical time to do more complex things that's needed for them, rather than scribing through loads and loads of notes and things. So yeah, diagnostics, I think we'll start to see that. We've seen the starts of it over the past few years, but I think we'll start to see the NHS in particular accept and adopt automated reporting of diagnostics, freeing up radiologists from doing basic reporting of chest X-rays to look after more complex care as well. And sentinel monitoring, I think that's the other key piece of bringing in the medtech devices and what I was saying about the wearables, and all the data insights that's being pulled together from multiple different systems and from different providers, whether it's the GP, the community care, or the acute care, bring all that together into what's actually been seen in other countries, and having command centres. So I know we've spoken in the UK about having command centres for ICSs, but actually having command centres or command towers that gets to see all of this data coming in and do actionable insights and prevention, rather than, I think we're still quite stuck on telling the patient that there's something going wrong and phone your GP or phone the whichever care provider is the best for you. But actually you could bring all that data together and actively prevent and actively provide insights to the patient, the clinicians around their care. So I think that's what we're going to start to see things. I think things are quite exciting in 2024 because of some of the big global health or global tech providers creating things like your Chat GPT and MedPalm and things like that. I think we'll start to see them being used, but I don't think it'll be until the end of the year that we'll start to see some actual healthcare use of them. And then it'll probably, unfortunately, be a few years before that before we see mass adoption of large language models and predictive AI in healthcare, because we're cautious.
I think we've lost our host.
Oh.
So I think I'll just keep going around the table and I guess carry on with the question. I think from my perspective at Careology, I think everything that's been said as we go around the table here, there's nothing I wouldn't particularly disagree with. Neil, I totally echo your points about the foothills. If we're looking at a 12-month horizon and what I think is going to change in 2024, I'm not expecting kind of huge kind of paradigm shifts in a 12-month window. But I think what we are undeniably seeing is increased acceleration and understanding for the opportunities that digital presents for healthcare at large, which let's face it, has always been a fairly traditional space. And we haven't been kind of the early adopter in Europe or the world, but we're certainly seeing that acceleration now and understanding for a lot of the opportunities that the digital presents. And I think that picking up on some of the trends that have already been mentioned, I think, Mark, you mentioned interoperability. Interop kind of comes up in pretty much every conversation that we have with providers, both in the UK and overseas. We all know that for digital adoption to really work, the doctors, the physicians, the nurses don't want yet another system they have to log into to access the data that they need to see. So I certainly think that interop is front of mind for everybody, and being able to make sure that data can effectively flow between different platforms, obviously in a safe manner. And Marcus, to your point, making sure there's real rigor around data security, and no one wants to be that company that becomes the one that creates that case study in terms of what not to do that you were alluding to, Marcus. But certainly interop and how we use data to better predict, better prioritize, and I think better personalize patient experience are three trends that I really think we're going to be seeing an awful lot more of. Interestingly, I think I scribbled down before, in cancer care, almost like the gold standard has always been really hands-on care. And it was almost like the best possible care was how frequently you could see your patient face-to-face and be hands-on and build that very close patient relationship between doctor and the person being treated. But I actually think now as we move forward, the gold standard is going to become much more about how we can be hands-off. And actually that benefits everybody. If I'm the patient, I don't want to have to go into hospital for endless appointments, for every consultation, every blood test, every examination. Increasingly comes back to data. How can we use that data to really understand which patients do need to come in for that appointment, that consultation, versus which actually are in good shape, can stay at home, could fill in a EPROMS questionnaire, for example, be able to use a wearable device to be able to monitor that person's vital signs or health status, and actually keep people out of the surgery as much as possible. So for me, a huge trend is how do we use data to enable better patient experience, which is not endless trips into hospital, allow you to get on with life as normal as much as possible, which reduces cost for the system. It can increase capacity, which is something we know we are very short of, especially in cancer care. It's in the papers all the time at the moment. Start to go on top of cancer backlogs, which is still a very big problem post-COVID. And I think lastly, I'll just say that for me, a word we use a lot is augment. I don't see digital in any time soon as being the replacement for hands-on physical care. No one wants that to happen. But it's how do you find the right blend where, of course, some consultations, some appointments need to be hands-on, and you will want that face-to-face relationship with your doctor. But actually, a lot of those appointments don't need to be face-to-face. So how do you augment in-person care with digital and make sure we're getting the blend right, which can add significant value for the whole ecosystem, allowing doctors and nurses to do their jobs better, allow patients to play their role in their own health and their own diagnosis more effectively as well, and enable better support from friends and family acting as caregivers. So really connecting that whole kind of healthcare ecosystem, which yields better results and better value for all the main players.
Great, thanks for that, Paul. Martin, did you want to come in?
Yeah, I just want to pick up something that Paul said about this face-to-face interaction between doctor and patients, and I think you are correctly right. It's not at all necessary always, and not even in telemedicine. What we use in our clinic is often asynchronous chat communication. Then the patients can send a text message, and then the doctor will send and ask a response, maybe a few hours after that, and that is very, very valuable for many patients, because you could have a continuous communication with the patients, and it's it's not so much problems with misunderstanding either, because everything is in the text. So if you have a video chat communication, there's a lot of things that you miss. So that's why text-based communications could be very effective, and the doctor could treat many patients at the same time with the text-based asynchronous communication. So that is something that we use a lot, and I think it will come a lot in digital care. Someone also said something about the pharmacy and the drug industry. And of course, I'm working with obesity, and the big companies now in the world, they are working with obesity drugs. I think you've heard about Novo Nordisk and Lilly. They are the big pharmaceutical companies now. And since obesity is so extremely widespread, 15 million people in UK, I read, have obesity. So this will also change healthcare a lot with the drug industry for treating obesity. That's just a comment. Thank you.
Thanks for that, Martin. Can I ask an open question, and maybe one of the panelists can pick it up? We've talked a lot about where we see things moving. Can I just ask, what are the barriers or the enablers or those things that, were they to change, would accelerate some of that process towards a much more joined up, data-driven approach to patient care?
So I'm happy to start if that's okay. So I think the biggest barrier is always investment. Now, I'm not talking about private investors investing in health tech companies. I do actually mean the healthcare providers investing in digital health and being ready for that digital health. We've seen some, the 2 billion that I mentioned earlier of frontline digitization. It's nowhere near enough. When you separate that down into how many organizations there are on the NHS, it becomes really small. So I think we're going to need at least 3 to 4 to maybe 5 times that over the next 5 years, and continuous as well, to be able to keep up. So I think the investment, also the cycles of investment within the NHS is always a problem. we have what's known as Mad March, where everyone spends their money at the end of March because they only get the money really released from the system towards the end of the calendar year, and then you end up with 3 months to just try and spend, which drives a tactical spend rather than a strategic spend. So we don't invest in healthcare in big, long strategic solutions because the money comes through too quick. Got to spend it before the end of March. And I think we've seen a slight shift in that with 3-year planning from the government and from NHS England on that, which has helped massively. But it still always happens that around January you get your budget of what's left to spend, and it's normally quite big sums of money for each NHS trust and provider, and it is then just a breakneck speed, try and spend something so you've got an asset by the end of the 31st of March that you can claim you've spent the money on, and that doesn't drive a good culture of strategic investment, unfortunately. I think the other one is post-pandemic, we're seeing the greatest pressures on the NHS ever. Waiting lists we've spoken about through the roof. Trusts are operating in what's called an Opal 4, which used to be called Black, but it means it's the worst dire situation the trust can be in. Not enough staff, too many patients coming through A&E, patients waiting in corridors and things. We're probably back to seeing scenes probably worse than when I first started in the NHS 25 years ago, where you would have patients waiting over 24 hours to be seen in the emergency department. Those pressures mean that the clinicians and even the operational staff are just busy firefighting day to day, which means they haven't got the headroom to really think about what's next and how to plan a decent digital strategy and implementation of the tech. They might get the money last minute to go and buy something, but then they haven't got the resources to actually implement it or implement it well and make it sticky and really take place and get the benefits out of it. And the other one is still, as we said, it's getting the basics in place. So the NHS is still working towards the basics of digital health, of having electronic patient records and core departmental systems. There's only a few that have achieved a decent level, and only a few that are able to really start thinking about the next levels of innovation. So I think that's the barriers, and that's the context that we're working in. I think we've all got to try and shift that, make it as easy to implement, but to make technology as easy as turning on your PC and open up Microsoft Word and getting started, not make something that takes 24 months to implement a technology that's then old technology by the time the clinicians start to use it. So yeah, I think they're the key barriers for me.
I'm happy to,
any more, Paul?
I'm happy to jump in, Alistair, with a couple of thoughts. One is the need for evidence, where I think certainly all of us on this call, I think, are advocates for adoption of digital. But we know that increasing, trust, like we work in an evidence-based sector. Now, I'm someone who feels very passionately that building the evidence and be able to demonstrate the impact that digital solutions can make, it's not necessarily a quick win. It takes time, but every company operating in the space, I think, needs to have their own strategy for how they demonstrate the impacts that they are able to provide. And it makes sense that our buyers will want to see what are the impacts that your technology can make in order for us to procure your service. So that is important, and everyone needs to have a focus on that. But at the same time, I think there are some things that just make sense, and trusts need to get on with stuff and implement solutions that make sense and can demonstrate even those initial nuggets that you're starting to make an impact in the sector where you're operating. Because until you get more and more adoption, it's very hard to have enough data to prove the impacts you are able to make. So we need just to get on with stuff and start deploying more. And to Neil's point, that needs additional budgets. And I think a real top-down approach. I'm often quite surprised, which I think is a challenge, at how much autonomy there still is within systems, healthcare systems. So even within a trust, you might have your real champion who's bought into what it is that a particular digital health company does. They sign that check, they get going with the initiative, but then actually to break down those doors internally and make sure that it's adopted properly, it's rolled out properly, there are still internal challenges. There's a change management piece. And I'm often surprised at how it can still be there can still be real autonomy, even down to a particular doctor or specialist level, as to whether they want to use this new toy that they see their bosses, spent money on implementing. And they can kind of shrug their shoulders and say, well, actually, now I like working the way that I've always worked. And I think there needs to be more kind of top-down directives around to overcome a lot of the challenges that we face as a healthcare system. We have to adopt technology, and it's not a choice. We've jumped through hoops. We've checked this solution is sound. There is evidence for it, so much as that is possible at this stage, and we're now going to get on and deploy it, and you have to get on board. So I think that those for me are a couple of the challenges which I think we need to overcome.
Mark?
Just building on Paul's and Neil's points, it's very clear that the only way we're going to get out of the hole we're in is that we're going to have to innovate ourselves out of it, because the bottom line is there isn't enough resource, even when you allow for things like strikes and winter pressures and so on. And the only way we're really going to get out of this is by innovating and rethinking pathways of care. And in part of that, and to Paul's point, scaling up innovative solutions is difficult because of the disparate nature which the NHS is, and the fact that kind of connectedness doesn't really exist. Now, some of the changes within ICSs might make that more realizable, but nonetheless, there is a lot of autonomy, quite rightly to some extent, but being able to learn from one region and being able to apply that quickly and at scale doesn't happen very easily because of the disparate nature of how things are funded, how decisions are made, how strategies are formulated, and so on. So once you've got a strong evidence base, being able to scale that up quickly and being able to continue building on that evidence base is something that's still quite lacking because the infrastructures don't quite exist. There are some things that are starting to be put into place to make that happen, but that's still quite lacking. The other, I think, is value-based procurement and the ability for collaboratives of both the NHS, third-party providers, and other sources of innovation to work together, because the reality is that there is no one solution that is the silver bullet to any of these problems. Actually, we need to take the best of multiple capabilities and be able to splice them together. Now, that might mean that there is some crossover and we have to manage those. There may be IP issues and other challenges that come about, but unless we can collaborate, unless we can use best in class and try to consolidate that and move that together, that is always going to be difficult. And unfortunately, the mechanisms to procure are still quite sort of, slow in picking up on this. And often it's, you have to have a single solution, or, it's not very innovative, and they don't necessarily think about what the value is to the healthcare system. It might be around pricing, or it might be around a particular aspect of the delivery of the solution. And so being able to have true value-based procurement, I think, is something that needs to be done. And I think this has been touched on before. It does all boil down to money. Now, that might be being able to use what existing funds you have more efficiently, or it might be centralized funding in order to both resource things properly. So, clinicians that are having to be faced down dealing and fighting fires actually have some additional capacity to implement properly these new innovations, actually gives time and space, and actually that might release some of the negativity that sometimes occurs when they're being forced to sort of deal with yet another new innovation when they're having to deal with the day-to-day. A lot of the solutions exist within the NHS, but unless you resource them properly, unless you fund them properly, unless you create time to make those things happen, it's very difficult. And that only happens when you have a medium to long-term strategy to make that happen. That does require some top-down approach in order to be ambassadorial about it, but you need to get the grassroots involved, and you can only do that when you free up time and capacity to make that happen. So all of those things, I think, is important. And then the last thing, I think, is the connectedness between healthcare and other agencies as well. We've seen with work that we've done around anticipatory care pathways that actually some of the problems facing healthcare are actually started off in social care, or some of the solutions for healthcare actually could be met by social care in terms of, moving patients out of hospital beds because they have a lack of social care infrastructure to look after them effectively. And in addition, some of the reasons why we have problems, particularly in winter, are because of exacerbations that may be caused by poor housing or mold in the house, exacerbating cardiovascular respiratory illnesses. And actually, the solution to that is not specifically a healthcare one. It might be actually paying for people to be able to afford their heating bill, or to prevent food insecurity, or provide them with the sort of social resilience that they require, so that their mental health is dealt with. And so that kind of biopsychosocial approach, I think, is one that is missing, and that connectedness between healthcare, social care, mental health, and other allied healthcare services is absolutely necessary in order to really have the success that we need for some of these innovations to take root.
Thanks, Mark. Marcus, I'm interested in your perspective. You work with a range of companies at different stages, and people that are developing innovative solutions. Is that speed to market a major issue? How quickly they can navigate some of the pathways to actually get their products or services into use and to patients and clinicians?
It's an interesting question, Alistair. There's certainly a break between having a great idea that has great social utility and being able to apply it. The number of game-changing applications that we see that do not make it in the long term because they don't find a way of translating what they have to offer into something that can be applied for people's benefit is huge. In part, it goes down to, depends on the market, but the market in the UK is because of the NHS has huge advantages, but also has certain barriers to entry. Unless you are plugged into the NHS, the remaining healthcare market is relatively small. In other jurisdictions, the dynamic is slightly different. Germany's doing, I think, more interesting things. To pick up on something Neil was saying about the UK falling behind in terms of funding digital applications from a state coffers, has meant that Germany, I think, is now way in advance of the UK. The UK was in advance of, I think, about 5 years ago, but we've definitely fallen behind. So we've certainly fallen behind where we were a year ago globally, where I think the uptake of digitally driven healthcare applications coming off the back end of COVID was huge, and then things seemed to grind to a halt. I would observe people went back to their old way of doing things, both healthcare professionals and patients, and it surprised me that there hasn't been a greater uptake of those digital applications. All that said, and Mark picked up on something right at the beginning when we're talking about the federated data platforms that are and apologies to Martin, this is a very UK example, but there are some nationwide programs that are running now, which I think will have huge advantages and applications in about a year's time, one of which with federated data platforms, the other is our future health as a sandbox for future developments. And I think that's why I think 2024 is really going to be a make or break year for a number of the interesting digital health applications, because they either find funding, either they get decent contracts to drive revenue, or they find funding from private equity, or they're bought, or they die. Because there are a lot of very interesting developments which deserve to see life, which I'm just not sure how they're going to get through 2024 unless there is that either consolidation or they can find a way of selling themselves into a market. Part of the issue, and I appreciate I've got doctors on the call here, is I'm going to stick my neck out because we're having a round table. We often see the most brilliant people we know who are doctors coming up with brilliant ideas, but then just not working out how they're going to monetize that. And monetization isn't a dirty word. You need money to pay staff and to further develop. And I think that, as I say, is one of my key themes for 2024. How are we going to monetize the the digital health applications that there are.
Thanks, Marcus. I think that probably tees up the sort of final part of this discussion, because I'd like to hear from all the panelists about their hopes for next year, shall we say. Before we do that, and before we start to sort of wrap things up with those summaries, is there anything that we haven't covered that any of the panelists would like to speak about? No? Well, I'm going to work our way around the table again and just ask, maybe for an optimistic view of your hopes, you know, if there was one or two big things that you think should represent a bit of a breakthrough over the course of the next year or the next couple of years, what would you like to think that would be? And we'll do that in order again. And if that's okay with you, Martin, I'm not picking on you.
I think that Paul mentioned something important. He asked for more research, didn't you? I think, and because digitalization, it also means that we could have data-driven research with electronic health records, and then we can really show that digital health care is more efficient. And also when we use AI and also machine learning that someone mentioned, I think that will be a big breakthrough in healthcare in the year ahead, because it will be more efficient care, I think, and we will prove it with research, and we could treat more and more patients with less effort. Digitally. That is what I see in the future. Thank you.
Great, thank you, Martin. You may already have answered this already, Marcus, but have another bite at it. The big breakthrough next year, your big hope.
I think there are so many people, so many large pharmaceutical companies applying machine learning to increasingly impressive data sets, that there will be some major drug breakthroughs this year resulting from the application of AI to large data sets, and I think that's going to take our breath away.
Great, thanks, Marcus. Mark?
We've touched on some of these points before, but I think some of the digital platforms that are starting to appear, particularly federated data platform and the associated system that's going to be created from being able to tap into that connected way of thinking, and digitization will start to create an industry on all of itself. And I think I'm hoping that some of the innovations that we've talked about will have a better chance of seeding in that environment, because actually the access to the type of data they require, the appetite for that data to be utilized, and being able to evidence the impact in terms of patient care will be much more evident, and therefore we can build on that in order to scale that quickly. And I think those things that will start to take root probably in the next 12 to 18 months, I think we're going to see a number of turnkey solutions starting to become much more pervasive. Great.
Thank you, Mark. And your hopes, Neil, or your sense of where the big breakthroughs you'd like to see happening over the next 12 months are?
Yeah, so I think if I go for my one big breakthrough, I think it's got to be the large language models. I would really like to see somewhere globally, it doesn't have to be the UK, but somewhere in the world, really put that large language model to use, and to prove something around discharge summary, something like that, to just prove that you could almost automate the first draft of a discharge summary to free up so much time within hospital for doctors for greater care. I've got many others, but I think I've probably touched on them. But I think a target operating model and greater funding are probably the other hopes to really make this the adoption, and a standardized adoption is where I think we've got to get to.
Great, thanks, Neil. And Paul, you get the last word.
No pressure. No, for me, obviously, you know, I've talked about cancer care, and for me, it really does break my heart when I open up the papers almost on a daily basis since the turn of the year looking at the ongoing challenges around cancer services in the UK. I talked about backlogs and 4-week wait targets being missed. So I really see a huge need, I mentioned before, kind of central government and NHS England to be making a much bigger play out of digital as a category. We really need to see much more of an emphasis on the role that digital can play in overcoming a lot of the solutions, a lot of the challenges that cancer services are facing, but it's not unique to cancer, obviously, as we've talked about at length today. But I think that there is mounting evidence and mounting recognition of the very significant role that digital solutions across diseases can play. So I certainly, my hope for the year is a much greater focus yet, more budgets being driven from the top that allow us to really start to embrace digital and deploy it properly. To some of Mark and Neil's points earlier on, as I said before, it's not good enough just getting your foot in the door, then making sure you can execute and deploy really effectively to really reap the very significant rewards that are there from all of the platforms and products that we've talked about this morning to fundamentally improve healthcare in the UK and beyond. So exciting times with challenges as well.
Thank you, Paul. And that concludes our discussion today. On behalf of Health Tech World, I'd just like to thank all of our panelists for their time, their insight, and their predictions. It's been a really interesting and wide-ranging discussion. Thank you to everybody that's watching. Please share this as widely as possible. It deserves to be seen by as many people as we can reach. And I'd just like to finish by saying once again, thanks to our panelists. I'm sure we'll follow up on some of the themes in specialised Health Tech World discussions over the months ahead. And please, have a look at the site and follow up on some of the content that we'll see coming through from Martin, Marcus, Mark, Neil, and Paul. Thank you.
Thank you, Alistair.
Thanks, Alistair.
Thanks all.